For now, I'd like to divert a little bit, maybe continuing on this theme of pushing the boundaries of clinical research practice by introducing our final panel discussion for the day, titled Peer Partnerships in Practice, Redefining Expertise in Clinical Research. This panel will be chaired by Jess Doumany, if she could come up. Jess is the research lead at the Australian Injecting and Illicit Drug Users League, and I've had the absolute pleasure of collaborating with her on this panel to really bring peer voices to the centre of the stage. We've put together this little panel with Paul Dessauer from Peer-Based Harm Reduction in Western Australia, Jack Nagle from Real Drug Talk, and Dr. Danielle Russell from the Kirby. She's a postdoctoral fellow at the Kirby Institute. And yeah, I'll hand over to Jess because thankfully she's chairing and I'm going to take a seat and maybe walk around with a microphone.
Thanks for that, Scylla. Is there a mobile mic? Is there a mobile mic? I think so. Oh, good. Thanks so much for that intro, Scylla, and thank you so much for being here, Danielle, Paul, and Jack. And I'd really like to express my appreciation to NCCRED for having a peer-based panel with the objective of combining lived and living experience of, in particular, methamphetamine use, to really look at basically the objective of this session is to provide a lived experience angle on how we can basically increase the engagement and input of people with lived experience into methamphetamine use research in a not just a tokenistic way, but a meaningful and actually embedded way across that entire continuum. So I'd also like to pay my respects to the traditional owners and elders of the Gadigal lands of the Eora Nation on which we're gathered, and also acknowledge the country and waterways that we're gathered on and the amazing cultural heritage of this amazing nation and country. I'm Lebanese by descent, and my dad's first generation Lebanese born actually in Sydney and grew up under White Australia policy here in the 30s and 40s. But whenever I come to Sydney, I've had the privilege of working mainly in the community control sector for about 15 years, and I'm always reminded of a visit I had with a traditional owner around Sydney who retold about when white man came, how the mob traverse through the trees up into the Blue Mountains, and that always just reminds me of, you know, the gravity of what's been destroyed to basically have what is here now. And just like to remember the grand scale of what was once here. All right, I'd love to also just preface that, look, this needs to be a safe space for everyone, and it's a big thing when peers contribute and share about their lived experience. So I'd just like to ask everyone to be respectful in your engagement. Sometimes stigma can come across without even people being aware of it. Very often I've been in conversations about stigma and people are making comments not even realising that they're stigmatising. So I'd just like to put that at the forefront. And, you know, people who use drugs, we're not commodities of research. We're not an industry. We're daughters, we're sons, we're mothers, we're fathers. We're human beings just like anyone else, and we have every right of place to be here. All right, so thank you. I just want to kick this off. So why is peer engagement important in clinical research to you? Paul, I'm looking at you.
G'day. My name's Paul Dessauer, and I'd also just like to acknowledge that we're on unceded Gadigal land. Always was, always will be. I'm here representing Peer-Based Harm Reduction WA, which is a consumer-led peer-based drug and alcohol agency in Western Australia. I've been working there for the last quarter of a century. But I'm also here as a person who uses drugs, because I'm a person who uses drugs, and that shouldn't be a controversial sentence for anyone to say aloud. I think everyone in this room is a behaviourally modern human being, And we're a hominid species that uses tools. And if you've never used any drugs in your life, you're a spectacularly unusual human being. But we're talking about some of the drugs I've used have been illegal ones. Some of the drugs I continue to use are illegal ones. And we're not just talking about stigma, we're actually talking about risks people expose themselves to when they admit to current substance use. Now, I'm a 59-year-old man with ischemic heart disease, so my current illicit substance use is kind of boring and very, very occasional. But it's difficult for people who are it's very difficult for anyone to speak from the position of currently engaging in an illicit activity without putting themselves at risk or their family members at risk. Yeah? And let's acknowledge criminalisation as an issue. And when we talk about stigma, I don't like using the word stigma. I think it's a weasel word. A stigma is a mark incised or tattooed onto a person to mark them as being religiously or criminally deviant. It comes from the 1600s in the English language. We're not actually talking about stigma. What we're talking about is prejudice. Okay? It's not a mark on me that leads to people treating me in a stigmatising way. It's something inside the person that leads to them doing that. And we all do it to each other about all sorts of issues. We all have internalised prejudices, and we need to understand them and recognise them. It's very easy to accidentally stigmatise people. Yeah? The way to not stigmatise people is to be really open and authentic in the way you engage with them and to ask them what they want. And whether we're talking about treatment or we're talking about research, it shouldn't be something that we do to other people. Okay? It should be something we do with other people. And so if you want your research or your treatment to be good, you need to consult the affected population. If you want drug policy to be good, you need to consult the affected population. And when we're talking about people engaging in a criminal activity, you need to work out how to do that creatively. Yeah? And if you want your research or your treatment to be effective, come to us and ask us what we want. And there's several times this afternoon, I've seen this being highlighted, where, even Elizabeth's presentation just then, what was it, a third of the people didn't want to be abstinent from methamphetamine. They wanted to get control of their methamphetamine use. And that's certainly been my experience of the people that I've worked with. I first encountered high purity crystal methamphetamine in the late 1980s. Most of my career from 2000 onwards working in this industry, my career before that was in a rather different industry, but most of my career since then has been focused on working with people who are having problems with their methamphetamine use. And a lot of people don't want to stop using right now, but they acknowledge that they're having problems related to their use and they want to work out how to get control of it. And medication-assisted therapy could be really useful for that. I first advocated for lisdexamphetamine agonist therapy for methamphetamine dependence at the inaugural methamphetamine conference in Prague in 2007. That's the year that lisdexamphetamine was first listed by the FDA in the US. I really want to see some progression in this area. We need to offer people treatment that works, and one of the other key things I got from this afternoon was the difference between the population in your study, Nadine, and in Rebecca's study. And a really large proportion of the people in Rebecca's study were in full-time employment. Yeah. Coming off a serious methamphetamine habit is not something that happens quickly. It can mess you around for weeks or months. And I meet a lot of people who are trapped in the position of needing to work full-time to afford the amount of methamphetamine they use and needing to use methamphetamine every day to be able to do the job they're doing. And so some sort of medication-assisted treatment's needed to stabilise in those sorts of situations.
I'm nodding my head, remembering back to scheduling a week to be able to stop.
And I'll stop talking because I just talked way too much, didn't I, Jess? Yeah.
No. I think it's... I just wanted to build on what you said there. Danielle and Jack, you're in sort of a unique position of straddling the community and academic worlds. I think we all know that peers need to be involved at research at every point, from concept through the translation and reporting. But I'm really interested to hear on how we can try and make that a safer place. I think we all know that universities often aren't the safest places. And how do we make these safer places for peers to feel comfortable engaging formally?
You know what? Can you guys hear me? Wait. Okay, there we go. I did like try my hand at writing like a care protocol for peer researchers, but it's a work in progress. And I think about it a lot though, especially because even watching other people that I've met and care about flail as they try to work hard, and it's always striking to me how much people who use drugs are like maligned as like lazy or shifty or shady, when it's like, from my perspective, I feel like I watch people try so hard, and if you spend a lot of time around people who use drugs, like I think that it would be hard to not notice that is oftentimes people that are trying like really hard to make things work. It's just like it's almost like the world is set up in a way that like they're gonna hit every sharp edge in life, and like bouncing off the like sharp edges, and no one put anything soft on the corners for them. And I think too, like when it comes to research, it's like there's this thing that like peer research, and it just is a systematic review, so I'm reading a lot of clinical research, yay. But it was interesting how there was one study in particular. It had peer, like it was basically looking, without like, I don't want to call out the person by name, but it was basically, it brought 3 people from 3 different positionalities, like sex workers, men who sleep with men, and people who inject drugs. And all of those 3 orgs together on the study. And so I was like, oh, that sounds great. Like, it sounds like great praxis. Then they actually used those peers to fingerprint their participants to make sure that none of them tried to steal the not payment they were not getting, I guess. Like, and then they actually even like inspected their bodies for track marks, which sounded so degrading. And they used the peers to do that. Like, so they actually like use the peers to do so much like not nice and rather cruel things. So it's like inclusion of people with lived experience, a long way to go, but like you can still have things go wrong even when on paper, like everything they did for inclusion looked great, but how they implemented it was still so much like an enactment of their own prejudice. And thank you for calling that for what it is, because that's what it is. This is like prejudice, and is often like abuse that's enacted against people that are like vulnerable. And I think the substance use is, and I said this in the last thing I was in, but like it's like a smokescreen for all these other prejudices that are less socially acceptable. Whereas like hating people who use drugs is like totally socially acceptable. It's encouraged. So I don't think that answered your question, but
No. Jack?
Yeah, I think for me, the thing that stood out today was Rebecca's presentation with the people that were employed. And my journey has been one where I'm not sort of a part of an NGO or the public system. I kind of come from outside of that and just have my own little organisation that we have social media and people sign up to our email list. And the large percentage of those people demographically as peers look completely different to how peers are represented in the normal stream. And I think the way that we capture and engage those people is incredibly important. Because, like there's just a few things with methamphetamine that just anecdotally, I think, more people smoke methamphetamine than they inject it. There's like, as we've heard today, there's lots of people that work. There's lots of people that are productive in their life. They're using it for practical reasons. I have a private practice. The last thing they want to do is talk about, I was talking about that with Paul earlier. The last thing they want to do is talk about their methamphetamine use. They want some other solution to practically get control of it and manage it. So I think just thinking about how we actually engage the actual population of methamphetamine users that are out there, the bigger population, and still take care of the segment that is intertwined in the system as it is at the moment, is really interesting to me, and it's been interesting today. And the other thing that I want to say is that I think it's important, obviously, to have peers in research to guide the way that research is happening, because people are just doing things anyway. Like I love to hear about the ketamine research and the psilocybin research, you know, because people are going out with their local shaman, drinking ayahuasca and shit in the middle of the jungle, doing crazy stuff anyway, you know, because they're looking for solutions. So, yeah, that's what NCCRED hasn't slipped me 100 contingency management to say this, but this is why I like NCCRED so much, is because it's researching the things that people are kind of exploring and doing anyway, and that's why it's important to have peers involved to communicate that stuff and say that this is what's happening out there and we need to guide our research in this direction.
Well, and people are going to talk differently too when someone who's directly impacted is in the room. That's what I've noticed. And then sometimes it's they really resent it, and it's palpable. You can feel it because having to change the way they speak. And
I think I think coming back to before, so we move on to sort of considering some distinct sort of priorities for methamphetamine research from a community perspective. Paul, how do you think, I mean, we've got the AIVL National Research Strategy. How do you think we can really, as peers and people who use drugs, take back control of any substance use research impacting people who use drugs?
Just a nice, simple question for me, Jess, yeah? Okay. I mean, we have a national strategy, but it's toothless. You can't engage in research with Aboriginal people without getting ethics approval and without engaging with community. And again, I think part of this comes down to the fact that we're talking about criminalised behaviour. We can't force research institutions to consult with us. I'd like to hope that people who want to do genuine and ethical research want to authentically engage with us, yeah? And I'm hoping that, I mean, AIVL has been through a real reinvigoration. The research strategy stuff, I'm hoping this is going to lead into a lot of the work we've done with NCCRED and with National Drug Research Institute and National Drug and Alcohol Research Centre has been really personality based. It's been that some of us know some of the researchers and we work well together, but we need stuff that's systemic.
Not just relationships based. And
yeah, we need stuff that's systemic and that's bedded in there and that it's part of normal practice, as this is how you go about research with this population. Yeah.
I think the importance too of sometimes saying no and having frameworks as to
I think a start to that is probably for national researchers, people who want to do research on a national level, go to the national peak body, go to AIVL. Don't approach drug user organisations individually and ask them to help you with your research. Go to our peak body and then get referred to the appropriate people, yeah?
Is there anywhere people can look up a kind of protocol? Like, especially myself as like a baby researcher, I have zero funding, fact which I'm very aware of.
There is an old AIVL document that was...
the ethics that's been updated as part of the National Research Strategy.
I think as well, something for me, I didn't complete year 12 and I just kind of got thrown into some research projects because I told my story in media, which scarred me for life. And I was just really lucky that there was like some nice researchers that sort of buddied up and helped me to understand what I was doing. But, I had no idea what I was actually advising on or the impact that it could have or, where the study was going or what the study was even about, So just having some sort of system that supports peers to actually learn about what they're doing before they actually start doing it is super important as well, I think.
Yeah, because I've noticed, just not calling out anyone specific, like, keep in mind I do work in research, so I'm not trying to throw too much shade here. But there's like, it's almost like keeping people who use drugs not so savvy about research is very useful. And I'm not saying anyone like does that on purpose, but I've just noticed a pattern of like, oftentimes it's almost like the peers or people who are brought in with lived experience are kind of steamrolled there. And they're left to feel like, oh, I don't think I understand. Because, like, after one meeting, I remember asking the person, so what do you think of the thing that they presented on? And they were like, wait, what? That's what they presented on? I was like, yeah. And it wasn't their fault that they didn't understand it. It's like the researchers had intentionally kind of like just bombarded them with information. And I don't think it's an accident anymore, because it's like over and over, this is a pattern. And like just throws a bunch of information at them. Then like they're overwhelmed. They go for like a low hanging fruit of like inclusion. And it's like, which of course, like, you know, good on them for trying, because they've just been given too much information to give like, you know, input and to really take advantage of their expertise in a way that's meaningful, I guess.
And just accept, like, what do you think are some of, like, I guess some mechanisms, processes to put that accountability and transparency back, I suppose, like.
I don't know,
There's no
'cause I knew a
sort of
researcher
consequence.
that would go, she would literally, is like everyone quit on her, she would just go to the gas station, like this in a bad part of town, and just pick up more people use drugs, even though a lot of them probably weren't necessarily just unhoused and like having mental health issues. But
Do you feel it would help having, like, if, you know, through AIVL and the National Research Strategy, formalising our own peer ethics committee and
yes, 100%.
decision frameworks and so on about what is actually safe, acceptable, and relevant research?
I almost hate to advocate for more bureaucracy, but it's like there's so much, the power imbalance is so disparate between, like, you know, people who use drugs and researchers, that unless you have it from a standpoint of like an AIVL that does have some power, and it's like it's just too disparate for it to end up like being as productive as it could be, which is also like a loss, because it could be some like really productive relationship with like reciprocal learning and synergy. Like, set on this opportunity for synergy.
Yeah. And just I'm interested in terms of considering sort of the domains in which you all sort of operate. Obviously, Paul being based in DUO, sort of community setting, and Jack and Danielle being sort of, I guess, within the academic area, and at a sort of bird's eye view of current priorities. What do you consider specific priorities for people who use drugs when it comes to methamphetamine use and withdrawal?
Okay. I guess Jack mentioned that, you know, not everybody who uses methamphetamine is dependent upon methamphetamine, and in fact the majority of people who use methamphetamine are not dependent on it. So they don't actually need treatment. You can forget about doing research for what treatment they need. They're not at risk of drug dependency. I think 45% or 40% of Australians in the National Householder Survey who said they used methamphetamine in the last 12 months said they did it 2 or 3 times. Now, that's not someone with a drug dependence. That's someone who went to a couple of parties or went to a couple of festivals. Yeah. But they're at risk of acute harm. And, you know, we need to have some good solid harm reduction stuff in place for those people.
Yeah.
Most people who use methamphetamine in Australia don't inject it, they smoke it. And they usually imagine that that's a lot less dangerous than injecting it. Most of the people I meet who smoke it get more dependent faster than the people who inject it. That's my rather anecdotal observation. I can provide sterile injecting equipment to people who are injecting methamphetamine. In Western Australia, I cannot provide them with a smoking implement. It's illegal.
Yeah. I know quite a few friends who've transitioned to injecting for the fact that they can't get in trouble having a fit kit in their car.
So some solid harm reduction stuff is something that's sorely needed in the Australian population. Yeah, and I guess the other area is this area of people who are dependent on the drug but are functioning. You know, I used meth on a daily basis for a very long period of my life in low, consistent doses. And I had lots of friends who had no idea that I was injecting methamphetamine every day. They thought I was a very efficient person. Yeah, it's a performance-enhancing drug. We wouldn't be giving amphetamine-type stimulants to combat pilots in multi-million-dollar aircraft in active war zones unless it made them more functional. But they're getting about 1/10 the dose that most people using the drug recreationally use. So a lot of people don't want to stop using the drug. They want to get it back to where it's functional and where it's not messing up their life. And it's something that I can imagine an agonist therapy could help people get control of their use again. If their ultimate goal is abstinence, then we know that a gentle taper rather than abrupt withdrawal allows you to function better as well. You know? It's rather hard to manage a staged tapered withdrawal over 2 or 3 months when your only access is street drugs that are unpredictable purity and that they're difficult to attain. But if we could, Australia does have the world's highest rate of meth use. I don't know how many people in the room realise that in 1974, Australia had the highest rate of amphetamine, non-medical amphetamine use in the English-speaking world, according to the World Health Organisation. This isn't a new thing for us, yeah? The difference is in that 1974, people were taking diverted pharmaceutical dexamphetamine. They knew exactly what dose they were taking every day. They were taking it by an oral route of administration generally, yeah? So there are ways to regulate substances. And I think part of the broader conversation is around the criminal status of these drugs. But what I want to see in the immediate future is research around harm reduction for people using meth and research around agonist replacement therapy. Yeah.
I think anything that shifts the optic off of like just individual and more systemic and like more like higher level, like bird's eye view type thing that, you know, kind of resists this urge to decontextualize and depoliticize drug use and make it seem as if it's just a pathology of individuals and not like an overarching pathology in like the way we treat people, the way that we like treat human difference, I guess. So I think that that's where research can have I feel like I'm like losing my religion a little bit. Like I used to think, not that I used to, okay. I still believe this, that research can be like a powerful force for like positive social change. But sometimes it's, you know, it's so like incremental. It is a bit hard to like, I guess, feel that it's often not fulfilling, especially when, you know, people that are experiencing so many like dire, real pressing needs. But yeah, like research could be this like positive force for social change. And I mean, and to pretend like the traditional research orientation, that like objective research doesn't have like a goal or something.
Are there any sort of examples that you know of already, like where there are sort of, I guess, mechanisms for active feed-in of direct, I guess, community voice to direct what research needs to be?
I mean, I guess there's like community boards and stuff that try to, you know, give input. But then I think it's almost like, I think, I'm not like, oh, like, what you need is people like me, but like, even like supporting more people to build their capacity to be integrated across all levels of research, not just as like objects of research or like people you're going to extract like a little bit of like input from, or like get their opinion on things. Like if you have it so it's like you have just holistically integrated, which and that's what one of the things I think is like a flaw with the way that lived experience workforce is being built, is it's like very much like siloing it as this like little thing on the side that like that's where you're going to make it into like people that are more marginalized, and you're not going to empower them because it's they're just going to end up in this little silo of objectification where they're limited. You're losing out on all the benefit that you could get from this partnership. So as well, so
Yeah.
I don't know if that was clear, but
Yeah, so I guess genuine involvement of lived and living experience doesn't mean you have a person with lived experience on your panel. There's a lot of people working in research with a lived and living experience of using illicit
not
drugs
comfortable
who
to
just
disclose.
aren't in a position to disclose that past experience or present experience. And I guess so that first piece of advice for researchers is don't just have one person who's your token lived experience person. Engaging with agencies like AIVL member orgs allows you to tap into a much broader, you know, if you're only going to have one person there, make sure it's someone who's tapped into a network so they're actually feeding information. You know, the service I work for sees like 75, 80 people every day of the year, apart from public holidays. None of those people are in a position to actively advocate on their own behalf in public forums, but they give us information that we then take to that advocacy. And the second bit of advice I would give is if you're doing research around treatment for methamphetamine dependence, think very carefully about what your outcome measures are. Don't make it all dependent on days abstinent from methamphetamine. My experience tells me that days abstinent is not necessarily as significant in terms of my ability to function as dose per day. Yeah? So maybe you see someone who's no really significant shift in how often they're using, but they're starting to moderate their dose more. Ask the person about outcome measures that are meaningful to them. Their ability to function, their ability to work or to seek work, their ability to parent, their relationships with people they care about, their, the prolonged chronic stage of methamphetamine withdrawal is really about, things like problems with depression and mood, emotional ability, getting irritable, snapping at people you care about. It's about not having the ability to concentrate or focus on things properly. It's about having problems with your memory. These are all things that, guess what's really good for fixing these things? Yeah? So we know that stimulants help people with all of these issues. That's why we prescribe them to people with attention deficits. Yeah?
I think
So if
and it's getting the right conditions so much of the time.
Yeah.
You see like aspects of a study where it's like, oh, that might work, but the duration's too short, or there's you can't expect people to make sustainable change in a matter of days without any wraparound supports, let alone using a medication.
So those problems when you're withdrawing from dependent meth are the reasons why people relapse, because you're putting up with that for weeks and weeks on end, and you know that you just have to spend $50 and you're going to be functioning fine for a couple of days, yeah? It's the reason why a lot of people who have co-occurring psychosis use methamphetamine. We're all concerned about the acute phase when the person's psychotic. We're not concerned about the chronic phase. So the negative symptoms of a psychotic disorder are depression, problems with mood, problems with concentration. Guess what happens when you take meth? Suddenly those problems don't seem as serious.
Well, you said, Jack?
I think I'd be, for people that are dependent, the people that we talk to, or that I talk to, I'd be deficient in my duty of saying that the thing that people are screaming out for is having a drug replacement therapy that is acknowledged, like opioid dependence. Like, that is just something that's just needed for people that are dependent. That's just what people want and are asking for. And people, I know people that will just go in and lie and make up that they have ADHD and stuff like that just to try and get their hands on, like trying to find a way to get support and help. So, yeah, that's just one thing that I would say that just needs to be, just pushed so much with more research, is just that thing for people that are dependent to have.
And I've worked with lots of psychiatrists who have quite confidently told me that adults with undiagnosed ADHD frequently self-medicate with psychostimulants. Guess what the exclusion criteria for being prescribed psychostimulants for ADHD is? Previous misuse of psychostimulants. Doesn't make any sense to me.
There's another peer researcher that I have a lot of respect for, David Frink, and he writes one of the first articles of his that I read, and my little drug using heart just cheered. It was called like, oh my gosh, like I wasn't sick and I didn't need to recover. Yeah. And it's like, in it he talks about how like methadone is replacing one drug with another, and he goes over how like risk environment framework, like that's actually why it works. And like that's what upsets a lot of people about methadone, I think, because it emphasizes that so much of the suffering, so much of the negative impact is like totally preventable. And that's like what breaks your heart when it does like settle on you and you realize like, holy shit, like none of that was even necessary. Like none of that like even had to happen. It's not something innate in the person. They weren't, every time I've gone to a funeral coming out in North America with like the fentanyl crap, like going to funerals where people are like saying they lost their battle with their demons, and it's like, it's always someone who wasn't there that says that, because it wasn't demons. It was like just total lack of support and like undercutting people's stability at every turn. And it just feels like you watch this slow social murder over and over and over. And I don't know where I'm going. I think I'm taking this too dark, but yeah.
Okay. No, thank you. I know we're time bound, but I know we want to have some time for questions. Have we got any questions at all?
No.
Yep.
I'm coming.
I work in South Australia, for Drug and Alcohol, South Australia. It's my ignorance. I've always wondered what the prescription of methamphetamine would look like. I mean, I like watching Second World War documentaries,
Yeah.
and there's a lot of history there. Is that something that's done, and would you advocate for it?
It was quite widely prescribed at one point in our history. It's still prescribed in the US under the trade name Dessauer, but it's for treatment-resistant obesity and narcolepsy. It's prescribed so infrequently that if you're a doctor and you want to prescribe it to someone, you have to write a letter to the federal authorities explaining why you want to do it, and then you have to write another letter to the pharmaceutical company asking them to manufacture a batch for your patient. There isn't that much pharmacologically to distinguish between the effects of dexamphetamine and methamphetamine. Methamphetamine gets across the blood-brain barrier more efficiently. It sticks around in your system. The duration of action is longer. But a medical dose of methamphetamine is pretty much indistinguishable from a medical dose of dexamphetamine and its effects. So if I had slipped, 5 to 10 milligrams of methamphetamine into your drinking water before this session started, if I had done that as some sort of evil experiment, you probably wouldn't have noticed. Okay, you'd probably just think you're having a good evening, and you would have gone to bed a lot later tonight than you normally would have. But it doesn't have that huge rewarding effect on those sorts of doses. Yeah, I mean that would be the ideal replacement pharmacotherapy. We're not going to get there politically. There is so much resistance to prescribing psychostimulants to people who use psychostimulants. The reason we have methadone, not heroin-assisted treatment in most countries, is the same reason, yeah? So in my opinion, lisdexamphetamine is probably the next best alternative as a agonist replacement therapy because it's long-acting, it's got much lower potential for diversion or non-medical use. It's just not as fun to play with as actual dexamphetamine or methamphetamine, yeah.
Thank you.
I thought that about fentanyl too. I always thought it has a low recreational factor, I guess, if you will.
Nah, you're wrong.
No, it really is so sterile and soulless feeling, especially coming out of the Southwest where it's black tar and it's so close to.
Yeah, I've heard the same.
There's so much plant material still in it. It's quite natural, not natural, but it's much less synthetic. And then. So I think the Southwest was one of the last places in the U.S. that was the holdout for heroin before. I mean, you can't.
It's quite hard to get heroin these days over there, isn't it?
Yeah, I feel like it's a little overstated because researchers have people the same people that they kind of talk to that they can't find heroin, and it's you sit in their meetings and the researcher would be like, you can't find heroin anywhere these days, and it's in your pocket, and you're just yeah, hard to find. But,
Have we got any more questions? Yeah.
Hi, fantastic panel, thanks for it. Simon Lenton from the National Drug Research Institute in Perth. I think it's kind of timely at the moment that we're talking about procedures for engaging people with lived experience in drug research because the NHMRC is reviewing its ethics model and so on for consumer involvement in all medical research. They had a national inquiry and there was opportunity to feed into that. And it was interesting when they talk about consumers, they don't talk about consumers in the sense that we talk about them. They're talking about treatment consumers. But there's a great opportunity for this discussion to be broadened and to fit into that network at the moment. The systems aren't perfect. It's not going to be a perfect outcome, but I think it's a timely opportunity. And I think the work that AIVL's doing is fantastic, and there might be a way to fit that work within the NHMRC review. Thanks.
It's interesting because
Awesome.
That's great to hear, thank you.
It's so much smart people, writing up all these things. And when you read the NHMRC statements about consumer inclusion, it sounds great. You're just oh yeah, well done. But then when it comes to funding, suddenly all these really smart people just oh, oopsie, oversight. There's not substantive support to implement all these great things they've said. And it's oh, bummer, because it sounded great. Like, it sounded great. Good job. But, man, like, just falling down on the implementation there, and it's a bit of a bummer, because that's, like, the practical part needs to be the follow-through as well with the new consumer statement. Like, I hope, because I was reading it, too. I was like,
Yeah, no,
Sounds
that's refreshing.
Yeah, but there is an opportunity to feed that in, and
Okay.
we like to do that, so we should be keeping on saying that, because a lot of their processes don't actually work for people who are consumers as well, you know? Do
When-
a track record of academic publications.
well, even as a researcher, I don't have funding to, like, pay people to participate and, like, to support the inclusion. Like, I would have to either ask people to, like, donate their time to me, which is not
Yeah.
appropriate, or, like, have to have, like, you know, a senior researcher that's, like, supporting me, which is also kind of, like, it's just, there should be, I guess, more mechanisms to support inclusion that actually, like, the practices of inclusion, not just the performance of inclusion, I guess.
The one thing I just want to say to researchers in the room today is this isn't a plug, but I've got a small podcast, and the most like we do people's stories, and the most popular episodes are when we have researchers come on and talk about the trials that they're doing. They get the most numbers. So people are interested in the trials. It's just about like engaging them and finding them. So yeah, like people want to get involved in what you're doing. So you know, like let's work together and make that happen a bit more. Yeah.
Any other questions? All right. I'll wrap up. I guess we're probably at time, I imagine. Thank you so much for participating and sharing, and thank you all for your participation.